Welcome to the March 7th session of the Phoenix Congress, where we are writing a blueprint for a better America. This legislative package will end poverty with universal basic income, end mass incarceration with major criminal justice reform, and end the endless wars by bringing our troops home and reducing our military budget. Today's session is the 15th of 21 public hearings on the 2022 legislative package, and we will review sections 401 to 414 relative to a public option for health insurance and requiring negotiation of prescription drug prices. These sessions will alternate between Mondays and Thursdays at 1:30 p.m. Eastern through March 28th. For those following along at home, you can find a link to the legislative package in the description below or at bit.ly/B, lowercase Dropbox. If you have questions about today's sections, you can submit them in the chat. And if you'd like to offer questions or other testimony for future hearings, please use the link in the description below. Before starting, I'd like to invite you to join us in reciting the preamble to the Constitution of the United States to remind us of our duties as Americans and set the intention for what we are trying to do today. We, the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, do ordain and establish this Constitution for the United States of America. With that, I'd like to welcome the delegate from North Carolina's 9th District to continue his testimony on the blueprint for a better America.
Thank you, Mixed Chair. For the record, my name is Brian. I'm an organizer with the American Union and a Phoenix Congress delegate in good standing, representing North Carolina's 9th District. Today, we're going to start on Title 4 of the blueprint, promoting the general welfare. And Section 401 is the findings, findings and purpose for this title. And so I would just like to briefly read them into the record. The Congress finds the following. 1. Americans have a constitutional duty to promote the general welfare, and Congress has an additional duty under Article 1, Section 8 to provide for the general welfare. 2. Welfare is defined as health, happiness, prosperity, well-being, and a logical way to increase access to health care is to decouple employment and health insurance by offering a public option for insurance. This will further increase happiness and prosperity by freeing employees to change jobs or start their own business without risking loss of health care. 3. To improve the health and happiness of families, America should join the ranks of every other industrialized nation in offering paid family leave. 4. Instituting universal basic income through the American Union Jobs Program will improve the lives of the 140 million Americans who are living in or near poverty, including tens of millions of children, by ensuring basic economic security, and further improve happiness for all Americans by reducing wealth inequality. 5. Universal basic income will also improve prosperity by putting billions of dollars into local communities, creating new customers for small businesses, and providing the startup capital for entrepreneurs to launch their own businesses. The purpose of this title is to promote the general health, happiness, and prosperity of America. And those findings pretty much sum it up. I think that concludes my testimony for Section 401, and I'd be happy to answer any questions.
Thank you. Seeing no questions, Section 401 is assigned to the Subcommittee on Findings. You may proceed.
All right, Section 411 is establishing a public option for health insurance. And I guess we should just clarify what exactly is a public option. This would be a government-run health program, and every American would have the ability to choose from that program or private insurance. Private insurance wouldn't be prohibited. This would just be an option for a government-run health program. And a public option has a number of benefits. Some of them include the fact that because it's government-run, it's nonprofit. Private health insurance companies make tremendous amounts of money. Government programs wouldn't have that same drive. Also, because it's a nonprofit, there'd be no taxes to pay, which would also help keep costs down. In general, administrative costs would be lower than with private insurance. According to the 2021 annual report of the boards of trustees of the Federal Hospital Insurance and Federal Supplementary Medical Insurance Trust Funds, which is the long way of saying the Medicare program, they reported that their administrative expenses were $4.5 billion, or 1.1% of their total costs. Put it another way, 98.9% of expenses went to benefit payments. And if you compare that to private insurance, they pay 80, 85%, maybe as high as 90% out in benefits, but they have a lot more administrative expenses, as well as profits and things that mean that less of their premiums actually goes to provide healthcare. A government program can do this with lower administrative costs. Government program would also have better bargaining power to compete with private insurers, because it would be one national negotiation. I don't know if you noticed that sometimes you get conflicting arguments from people opposed to this kind of thing. One of them is that, well, government is incompetent, and so that privatizing things is the way to have the most efficiencies. And the other argument is that, well, it's unfair if government competes, because they would be able to offer services at a lower price because of their size. And while the government may be incompetent on some things, if we can provide cost savings to the American people, as well as provide these other benefits through a public option, I think we absolutely should. Other benefits are, this would be portable. This is billed as part of the American Union's job program, which we'll talk about in a later hearing, that as every American gets an American Union job with and universal basic income, they also get the opportunity to buy health insurance, which they can take with them no matter where they are around the country. Give Americans the freedom to move around the country and have insurance and income move with them. And by being a national plan, it would further offer efficiencies. What do people think about a public option? And the vast majority of people support it. A March 2021 Politico survey found that 68% of voters supported a public option, a higher percentage than supported a Medicare for all. And so this is incredibly popular with the voters. 80% of Democrats and 56% of Republicans supported a public option, which is perhaps one of the reasons that Joe Biden campaigned on it in 2020 and defeated Donald Trump. But there hasn't been really any progress on providing the American people with a public option, despite the fact that our president campaigned on it and that more than 2/3 of voters would like to see one. And so we can address that in 2022 with the Blueprint for a Better America. Now, this section 411 is based on previous legislation that has been introduced in Congress, and it would add a new section to the Affordable Care Act. And just to kind of go through some of the details briefly, the Secretary of Health and Human Services would be responsible for putting together the public option and the specifics of the plan. Beginning in 2024, they would be offered through the healthcare exchanges that the Affordable Care Act set up. I also want to emphasize that the public option would be voluntary. No one would be obligated to buy their insurance through it. The legislation says so specifically on page 99 of the blueprint, that participation in the public option is voluntary. The secretary would put together a number of plans, the standard bronze, silver, and gold. If you've shopped for health insurance on the exchange, you're familiar with those. And then there would be an option for a platinum plan, depending on how costs and things work out. Premiums could be geographically adjusted, and premiums would be set in an amount to cover the cost of administration and health benefits. So figure out what will it cost, and then set the premiums at that, plus a 90-day contingency margin for unexpected expenses. And so these startup costs would be the 90-day margin plus $2 billion and that would be repaid over 10 years. So this would be a cost neutral to the rest of the federal government spending. There would be no bailouts. One other thing that specifically is specified in this legislation. This would be a completely separate program, self-funded, to provide health insurance to anyone who wants it. The public option would also require negotiation for prescription drugs. We're going to talk about that a little bit in the next section. It would set up a provider network. As the default, any hospital or any doctor who participates in Medicare right now would be included, but they would have an option to opt out after the program gets started. They start working out details in 2023. Doctors and hospitals would have at least a 4-month window to opt out, and then an annual enrollment period where they could change their status. The reimbursement rates, payment rates under the public option would be set at the Medicare reimbursement levels, plus there'd be a 5% incentive bonus for the first 3 years. Physicians would be divided into 2 classes: the preferred, who agree to accept this payment rate, and then participating non-preferred physicians who agree to cap their charges at 15% over their in-network cost sharing price. And then and anyone else, any other physicians or doctors who didn't want to participate would be non-participating. Subsection D of this section, it offers options for the secretary to experiment with different reforms and ways of bringing down healthcare costs. Some of the policies that they would be that they could try would include patient-centered medical home care. It would accountable care organizations, value-based purchasing, bundling of services, differential payment rates, performance or utilization-based payments, a fixed payment per person, or direct contracting with providers. And the secretary could try these out in different locations and sort of see what works. And then if they, pick out the best plans and expand them, roll them out nationwide. Anything that they tried under these provisions would have to quote promote care that is integrated, patient-centered, high quality, and efficient. In addition, it would also have to be aimed at least one of these 5 targets: improving health outcomes, reducing health disparities, including racial, ethnic, and other disparities, providing efficient and affordable care, addressing geographic variation in the provision of health services, or preventing and managing chronic illnesses. So any experimentation would be targeted at least one of those 5 things. Other subsections in this part, they include protections for individual health information. The same protections that apply to other health plans would apply to this too, including HIPAA. And so overall, this would give the American people another choice. There's a lot of reasons for people to be dissatisfied with healthcare in this country. As a nation, we pay more per capita than any other country on the planet, and leave tens of millions of people uninsured. So so there's better ways to do things. And the logical first step seems to be a public option, since our president has already promised us one of these. And and we saw during the start of the pandemic, some more than 5 million Americans who lost their health insurance coverage when their jobs went away. We need a better model for healthcare in the 21st century, and by decoupling employment and insurance, seems like a logical place to start. So, with that, Mr. Chair, I think that concludes my testimony for Section 411, and I'd be happy to answer any questions.
Thank you. Yes, I have a couple questions. I'll start with a very specific one. With target number 4, address geographic variation in the provision of health services. Is it possible that that could be negatively taken advantage of in a loophole sort of way to increase prices in certain areas rather than to decrease prices in sort of this kind of backwards interpretation of addressing geographic variation?
So that target would be if they were trying one of the specific options for reforms and experimentation, such as the differential payment rates or fixed payment per person. And so I guess I don't think so. I don't think you could. I think these experiments would be sort of limited in their geographic range. And so I don't think you could, for example, raise the rates of someone in New York to subsidize the doctors in Georgia or something like that. Is that what you're asking? Is if that would be a loophole where one geographic region would pay more, so another geographic region would pay less?
Potentially, or I mean, there are a couple of different ways that could go because, yeah, depending on what you want. So addressing geographic variation, I think you could have the philosophy that that maybe prices should be different in different geographic locations, or you could take the philosophy that it should be the same everywhere. I think I'd probably lean toward the former, but I think you could argue in either direction, and I think it would be good to clarify that potentially
Sure.
in which way we want it to level out.
Yes, the premiums can be geographically adjusted in subsection B. It says the secretary shall establish geographically adjusted premium rates for the public health insurance option. So it would not be one uniform price nationwide. Presumably, it'd be more expensive in high cost of living areas and less expensive in lower cost of living areas.
Okay, thank you. I'd like to welcome DJ Elf to the chat. Always great to have you. I do have a broader question. So you had stated that Medicare puts about 1.1% of their total cost toward administrative expenses, whereas private insurance is usually at least 10%. So the first question would be, do you foresee the government outcompeting private insurance almost completely? And if so, what would be the point of delaying that? Why not just cut to the chase and do things in a more efficient way?
Because politics is the art of the possible. And I don't believe it is possible for us to cut right to a single payer healthcare system at this moment. But the public option, is, I mean, so the arguments against sort of a single payer system have always been, it's socialism, it's taking away your choices and things like that. Healthcare is different than a lot of other services because it's not really optional. Like everybody needs healthcare. And so it's not really subject to the same sort of market forces that other industries are. But with a public option, we address that by ensuring that people have a choice. And if people want to buy private insurance, they can continue to do so. But it may come to a point where a government plan is efficient enough that that private insurers are less able to compete. We don't know. We'll find out. But this seems like a logical first step.
Thank you. Seeing no further questions, section 411 is assigned to the Subcommittee on Promoting Well-Being. You may proceed to section 412.
All right, thank you. Section 412 is relative to repealing eligibility restrictions on subsidies. For everyone who's looked at the healthcare exchanges set up under the Affordable Care Act, Many people are eligible for subsidies if they earn between 100% and 400% of the poverty line, unless you have job-based coverage. If your employer offers you a healthcare plan, and as long as it's affordable and meets minimum standards, you are ineligible for subsidies. And most job-based plans meet those standards. So if your employer offers you insurance, even if you don't take it, and even if you would prefer to buy a plan on the exchange, again, for some of the reasons that we talked about for the public option, so that it would be portable should you change employers, you wouldn't be able to qualify for subsidies just because you had an employer-based plan available to you. So Section 412 would repeal those eligibility restrictions so that whether or not a person had an offer for insurance from an employer, they could still be eligible for a subsidy on the exchanges as long as they're qualified in general. There's a number of I've heard a number of stories of people who, because an offer of health insurance was made available to them, it ended up, we've sort of created a disincentive here, right? Is if you are getting if you're getting help to buy your insurance, and then you get a job and your job offers you these same benefits and you lose that subsidy, then that can be a really high marginal tax rate that you're suddenly getting hit with. And so we've created a disincentive for people to seek jobs with health insurance if they're going to lose their subsidies. And so by getting rid of those eligibility restrictions, and just by setting a level playing field, anyone in certain income brackets is eligible to qualify. We can advance the way that we offer health insurance in this country by repealing that restriction. So that's what this section does, and I think that concludes my testimony, and I'd be happy to answer any questions.
Thank you. Yeah, sounds a lot like shifting from unemployment insurance to unconditional basic income. In a sort of, it's still not free healthcare, but it's you're no longer putting that, you don't have that condition on there anymore that ends up disincentivizing work. You get the option to get the option for a public option becomes a right rather than a privilege.
Yeah, and part of this is sort of a mindset of scarcity that we have in a lot of America in our policy, that there's not enough to go around, so we've got to make it difficult. We've got to put obstacles in place. We've got to before letting people have access to these things. And in the 21st century, we can shift to a mindset of abundance and say there is enough for everybody. Let's encourage people to do the things that will improve us as a society, that will promote the general welfare and the health, happiness, and prosperity of all of us. And so, yes, by getting rid of this bureaucratic roadblock, we can do that.
Fantastic. Okay, seeing no questions, Section 412 is assigned to the Subcommittee on Promoting Well-Being. You may proceed to Section 413.
All right. Section 413 is getting rid of another bureaucratic roadblock, which is the mandate for large employers to offer health insurance. Now, I've been a small business owner, and, when you start a business, it's because you have a specific, service or good or thing that you want to offer. You don't start a business because you want to provide healthcare to the people who work for you. Unfortunately, because in this country we've sort of coupled those two things together, it is a barrier and a burden for business. So the Affordable Care Act, it requires employers with 50 or more full-time equivalent employees to provide health coverage to at least 95% of their full-time employees. And it also sets minimum baselines for coverage and affordability, some of the things I referred to in the last section. Now, if employers don't do this, then they face annual penalties of, if they don't offer coverage, it's $2,750 per full-time employee for the 31st and upwards. Or if their offering isn't, quote, affordable or providing minimum value, then it's a $4,120 fine for any employee who qualifies for a subsidy on the marketplace. And so once again, we've created a disincentive. If you're a restaurant that has 50 or 60 employees, you've got an incentive not to expand, not to give them full-time employment. You've got an incentive to keep them at under 30 hours a week so that you don't trigger this mandate. You've got, an incentive not to expand too much, where all of a sudden you will have this new regulatory burden put on you. And we can take that burden off of business by offering a public option for health insurance and repealing the large employers' health insurance mandate. Now, just because you get rid of the mandate doesn't mean that employers can't offer insurance. This can still be a perk that employers offer. And, I'm sure it will continue to be one. But by getting rid of the mandate, it will again make the public option more accessible to larger numbers of people, so that we can, the bigger the pool of participants in the public option, the lower rates that the government would be able to negotiate and keep costs down. So taking burdens off of business is an important part of this section. And with that, Chair, I think that concludes my testimony for section 413, and be happy to answer any questions.
Thank you. Yes, it seems like part of this provision originally was fueled by this assumption that most people get by on one job, but the reality is that's not true, particularly if you can't work more than 30 hours. You're going to end up working two jobs, and then now maybe you're working 50 hours a week, but now you're not getting any health coverage. And so it doesn't really solve the problem of, even if you do come at it from this idea of people who work full-time should have health coverage, this creates a situation where people are working full-time and don't have health coverage. Because,
yeah, I'd like to come at it from the perspective that all people should have health coverage, whether they're working or not. And the public option and the expansion of subsidies will make that more possible.
Fantastic. Okay, seeing no questions, section 413 is assigned to the Subcommittee on Promoting Well-being. You may proceed to section 414.
All right, section 414, negotiating prescription drug prices. This has been a popular talking point for many, many years. President Biden mentioned it in his State of the Union speech last week. Yes, we should negotiate for prescription drug prices, and yet we don't. Last October, a Kaiser Family Foundation survey found that 83% of voters supported this provision, and yet nothing happens. Why is that? And and the answer is because it's very profitable for some companies to make sure that we're not negotiating for prescription drug prices. So what are we paying right now? Right now, Medicare reimbursements for most Part B drugs is 106% of the average sales price. The average sales price is the average price to all non-federal purchasers in the United States. So this is how we negotiate for drug prices. What is everyone else across the United States paying? And then we'll pay 6% higher than that, despite the fact that we're buying in bulk, and normally you would expect to get some discounts for that kind of thing. We have negotiated to pay above average prices, and this is completely backwards. The Nonpartisan Congressional Budget Office, they have estimated that allowing Medicare to negotiate prices would save government health plans more than $450 billion over 10 years. That's a lot of money, because we're not negotiating for these prices. As I said, this has been around for a long time. This language in section 414 comes from legislation that's been introduced year after year. in 2018, the Citizens for Responsibility and Ethics in Washington, they reported that, quote, the industry's biggest trade group has also increased dues for its member companies by 50% in order to raise $100 million for an influence campaign to stave off possible pricing regulations by U.S. lawmakers. You know, the industry is always concerned about what if we do the common sense, what if government does the common sense thing of negotiating for prescription drug prices. But let's just look at that number, $100 million for an influence campaign. We've got 535 members of Congress. So that's about $187,000 to each of them to persuade them not to disrupt the status quo. And again, if we're going to save $450 billion over 10 years, that's say $45 billion a year on average. So if you could spend $100 million in order to get an extra $45 billion in profits, that's a pretty good investment for the drug companies that are lobbying to block prescription drug negotiation. But that return that they're getting, that $45 billion that they're collecting in extra profits, that is coming from the American people. That is money that should be better spent elsewhere. And if we want, here's an opportunity for government to be more efficient and spend less by doing the common sense thing of negotiation. I just want to read what we have in our current, in the current law that was passed as part of the Affordable Care Act. And it says, it says non-interference is the name of the subsection. It says, quote, in order to promote competition under this part and in carrying out this part, the secretary, one, may not interfere with the negotiations between drug manufacturers and pharmacies and PDP sponsors, and two, may not require a particular formulary or institute a price structure for the reimbursement of covered Part D drugs. So this is sort of supposed to be in the name of competition that we don't negotiate, and that doesn't make a lot of sense. So Section 414 would repeal that and instead require that the secretary negotiate for covered Part D drugs for Part D eligible individuals and bring down the costs that we're paying for prescription drugs. Again, the United States pays more per capita for healthcare than any other nation on the planet, and by quite a wide margin. So there are those who argue that, well, if we don't give the drug companies such huge profits, they won't have the incentive to develop new drugs. I don't really believe that. So Section 414 will require them to negotiate for prescription drug prices. Again, this is a popular provision, and by including it into one legislative package, we can cut through the gridlock in Washington and get this provision to the president's desk. Mr. Chair, I think that concludes my testimony for Section 414, and I'd be happy to answer any questions.
Thank you. Yes, you said that this would require the secretary to negotiate prices for Part D. What about the other parts?
That is a great question. This language was lifted from existing proposals to require negotiation. But yes, looking at it, it should be expanded to negotiate for prices in all of the Medicare parts. And I'd be happy to work with the subcommittee on that.
Fantastic. Okay, seeing no further questions, Section 414 is assigned to the Subcommittee on Promoting Well-Being. I'd like to thank the delegate for his testimony.
Thank you. I'm looking forward to Title IV. The criminal justice reform and ending meaningless wars provisions are very important to a lot of people. But when it comes to promoting the general welfare, these are the things that affect hundreds of millions of Americans and that have a much broader impact. And these are problems that need to be addressed, and these are some solutions. I hope we can do it in 2022.
Yes, fantastic. Yes, absolutely. And ending those wars will affect many folks around the world, but this has a much more tangible effect for those at home who are actually participating in this process. Um,
Very true.
yes, and who get to make the call. Okay, thank you. Well, the next session of the Phoenix Congress will be held on Monday, March. Oops, nope. It will be held on Thursday, March 10th. We will review sections 421 relative to paid family leave. Or sorry, 421 to 427 relative to paid family leave. This hearing is adjourned.